Colleagues, we have a quorum, and I'm calling the meeting to order. Et je vous souhaite le bienvenue au Committee des Affaires sociales, des sciences et de la technologie. I'm Kelvin Ogilvie from Nova Scotia, chair of the committee, and I'm going to invite my colleagues to introduce themselves, starting today on my right.
Norman Doyle, Newfoundland, Labrador.
Judith Seidman, Montreal, Quebec.
Nikki Eaton, Ontario.
Rosemary Poirier, New Brunswick, and I'm filling in for Senator Nancy Greenray.
That's okay.
Carolyn Stewart-Olson, New Brunswick.
Marie-Françoise Mégy, Chantal Petitclerc du Québec.
René Cormier, Nouveau-Brunswick.
Art Eggleton, Senator from Toronto, Deputy Chair of the Committee.
Thank you very much, colleagues. Now, just remind everyone in the viewing audience that we are here today to continue our study of Bill C-277, an act providing for the development of a framework on palliative care in Canada. And we have two panels today. This first panel will end no later than 11:30. And on this panel, we have the Canadian Nurses Association, represented by Carolyn Pullen, Director, Policy, Advocacy and Strategy. We have from the Canadian Society of Palliative Care Physicians, J. David Henderson, who is President. And from the Canadian Geriatric Society, we have Dr. Frank Molnar, President. Welcome back. So, with that, I'm going to invite our panelists to start. I wasn't given an indication that anyone had a preference for going first, so I will invite you in the order that they're listed on my paper, and following your presentations, I will invite my colleagues to ask questions of you. So, in that case, Ms. Pullen, I will start with you.
Thank you. Thank you, Mr. Chair and committee members, for this opportunity to speak today. I'm a registered nurse and Director of Policy for the Canadian Nurses Association. We're the national professional association representing more than 139,000 registered nurses and nurse practitioners from every province and territory across Canada. I'm proud to say CNA's membership includes 1,350 nurses who have achieved CNA specialty certification in hospice and palliative care. CNA is supportive of Bill C-277, an act providing for the development of a framework on palliative care in Canada. In March 2017, we presented recommendations on the proposed bill to the House of Commons Standing Committee on Health. In follow-up, most of our recommendations were adopted by the committee, and we continue to support the bill as it was passed by the House of Commons. Today, I offer 4 recommendations to further strengthen a comprehensive regime for palliative care in Canada. First, there's a need for greater emphasis on a palliative approach to care in the bill, so I offer that for consideration. We advocate for a palliative approach to care enabled by advanced care planning. This evidence-informed approach focuses on improving quality of life for patients with a life-limiting illness by reducing suffering through early identification, assessment, and treatment of physical, cultural, psychosocial, and spiritual needs. With the required education and training, a palliative approach to care could be taken in all healthcare settings by members of an integrated care team. As you have heard from other witnesses, this could not only improve end-of-life experiences for patients and families, but it could also improve the quality and sustainability of a publicly funded health system. To further strengthen the bill, we suggest a revision to Clause A under Section 2 as follows. The language would be, defines what palliative care and a palliative approach to care is. Secondly, we encourage the committee to support the development and implementation of national evidence-informed standards for integrated palliative care. At the moment, there are no nationwide policies and evidence-informed standards to ensure integration of the palliative approach to care across the continuum. In addition to not having a framework, there are no standardized and widely adopted methods to guide healthcare providers, including nurses, on when and how to implement a palliative approach to care. The shortage of high-quality comprehensive health information also confounds the design and delivery of palliative care. Across jurisdictions, we still lack consistent data definitions and interoperable data collection systems. Sharing and linking data to other health and social data sets is challenging, if not impossible. Underserved populations such as First Nations, Inuit, and Métis are not well represented in the data, which impedes our ability to understand, assess, and improve care for these populations. Without being able to follow and compare performance, provinces and territories have a limited capacity to understand whether, where, and how to improve palliative care. National standards for integrated palliative care and comprehensive high-quality data would greatly enhance our understanding of system gaps and the impact on quality improvement initiatives. Therefore, we recommend that paragraph 2.1d could be revised to read as follows: promotes research and reporting on indicators related to national evidence-informed standards on palliative care. Thirdly, CNA supports the need to increase public awareness on palliative care via a national campaign that would include caregiver-targeted information on current federal government programs. Once legislation is adopted, the Minister of Health could play a key role in raising public awareness, especially among patients and caregivers. A recent report from the Canadian Partnership Against Cancer highlighted key factors to support a seamless patient experience. Nurses play an essential and central communication and navigation role, leading and supporting care teams, including patients and families, and nurses are central in ensuring smooth transitions in care. We have long known the most positive patient experiences occur when care is patient and family centered and models accommodate patient and family preferences. On its own, the fact that the majority of deaths in Canada still occur in hospital, while the vast majority of Canadians tell us they would prefer to die at home or in a home-like setting, indicates there is still work to be done. As an association, we promote promising models for palliative care and are proud to support nurses in Canada to achieve specialty certification. Finally, we support a key recommendation proposed by the Canadian Indigenous Nurses Association, also known as CNA, in its pre-budget submission to the House of Commons Standing Committee on Finance. Together, we call on the federal government to provide $25 million each year over 4 years for improved home care services, which include palliative care, to address the needs of rural and remote Indigenous communities. Every level of government must support equitable delivery of services to Canada's Indigenous populations, including access to culturally safe, high-quality health services on reserve and in rural and remote locales. A sustainable approach would be for all those who care for patients at the end of life in these settings to be knowledgeable about and have the tools available to provide a palliative approach to care. We also support CNA's recommendation that Indigenous knowledge and healing practices be incorporated into the service delivery framework and the management of those with chronic disease and requiring end-of-life care. We are currently working with CNA to find the best ways to incorporate Indigenous knowledge into home care services and care delivery. In closing, I emphasize CNA as a strong advocate for high-quality palliative care and a palliative approach to care accessible to all Canadians, regardless of where they live, and in settings that best suit their individual needs. Thank you, and I look forward to your questions.
We realize that there is a shortage of generalists who are trained in the geriatric field. We also heard yesterday about some really interesting programs that various provinces are doing, Alberta, BC. And as the chairman himself says, the problem in this country is that everything is so siloed between provinces, jurisdictions. Have you thought about how to break down those silos and share the various best programs amongst all of us, amongst all provinces and jurisdictions?
Part of the role of a national professional association is to achieve goals such as those. We really act as a hub in a hub and spoke model and work very collaboratively with the jurisdictions that we represent. So an example of where we have tried to identify promising or best practices and disseminate them as broadly as we can would be the example of specialty certification for nurses. In 21 different specialty areas, the CNA offers certification exams, and one of the ones that has good uptake would be the one in hospice palliative care. So that is one example of how we can encourage nurses who are working in in an area where they frequently interact with patients at end of life, to specialize in that area and to achieve what we would view as a national level standard that is evidence informed and should be.
Programs, this is what I'm saying. Do they cross over jurisdictions?
Yes, those programs, as an example, are any nurse in Canada who qualifies to take those exams is eligible to take them. But beyond that, we also, as a national association, have many free online and in-person opportunities to learn, to share information. And in fact, it's not just available to nurses. Right now in CNA's current context, many of our resources are available to all healthcare providers. And I think that that's a very essential consideration as we have this discussion, because in some arenas you will see resources that are restricted to only one discipline, whereas they may have received federal funding to develop those programs or resources, and that seems to contradict an aim to raise the bar across all health professionals so that you could have best practices, let's say, in integrated palliative care espoused by all team members. We know that those examples exist in pockets across the country where we can identify and share them. We do our best to share them across as many disciplines as we can reach. We try to remove artificial barriers to access to that information and really promote those models. So we're very supportive of that approach, and with the resources that we have, do everything to achieve precisely that.
The previous federal government put in place an initiative called the Way Forward, an integrated palliative approach to care, and it provided some $3 million over 3 years. A framework was created, and I think that's where the Secretariat, I guess, comes into play as well. It was part of that. So how do we move this along to a further stage rather than just reinventing this framework? How do we take what we've learned from that exercise and build upon it and make this a much more fulsome implementation of a palliative care program?
I would add that it's an evolution, and I don't view past initiatives that have taken root and then gone dormant or haven't progressed as rapidly as failures. They were steps. When I graduated from nursing in the early 90s, we weren't talking about palliative care. It wasn't part of the curriculum at all, yet here we are almost 25 years later, and it's a very important part of the conversation that has been advanced by the debates around assisted dying and changes in demographics, etc. So I would see the next step as building on the work that has already been done, but I think it can be done in a lean way that can rapidly advance us from where we're at right now, and I think the signals are all very good. You have the national organizations and stakeholders across the whole healthcare and social services spectrum aware of and talking about palliative care. So it's a great time to take advantage of a crisis and complete the work or take very substantial strides forward in making palliative care part of the lexicon and the practice of all healthcare practitioners, regardless of the setting.
Mr. Anderson?
Merci, Monsieur le Président. Ma question s'adresse à Madame Pullen. Dans votre présentation, vous parlez de delivery of services including access to culturally safe, high-quality health services. Alors, je suis intéressé de savoir de quelle manière les dimensions culturelles sont-elles prises en compte dans la livraison des services et comment ça s'incarne dans les formations qui sont offertes aux fournisseurs de services et aux aidants.
C'est une question excellente, spécialement en 2017 et les conversations qu'on a au niveau national à ce moment. we are very proud that we have a partnership accord with the Canadian Indigenous Nurses Association. In partnership with them and with our membership really quite embedded one with the other, we are highly attuned to the need to improve on cultural safety within health services and social services and other services in Canada. To that end, we are working hand in hand where CNA, as an Indigenous-led organization, really guides the CNA on understanding better what it will take to develop a health care system, including a palliative care component that really ensures cultural safety for patients and families and espouses a sense of cultural humility among the care providers who are interacting with patients and families every day. To support that, we do the obvious usual structural things like position statements on the subject which describe what we mean, knowledge translation around those tools to try to educate and share information. But beyond that, I think there needs to be a much more significant investment in awareness, development of competencies, and just a true cultural shift in understanding among mainstream healthcare professionals around what is required on our behalf to truly deliver culturally safe care. I'll add to that we work really closely with the most knowledgeable experts within the Indigenous Nurses Association to help us understand what is missing currently in curriculums, in other resources that reflect Indigenous ways of knowing, what is missing in the way care is actually delivered. Good examples that come to mind in the palliative care context would be things like, do you have policies in institutions where people can smudge and the fire alarms won't go off or you won't be prevented from doing it? Or beautiful examples from the First Nations Health Authority in British Columbia where they've actually been able to set up wall tents outside the concrete walls of the physical plant so that people can spend their last days in precisely the setting that is most comforting to them and their family, in light of the fact that specialized care may not have been available in their remote community, and we've asked them to move to spend their last days in a completely foreign setting. So there's an enormous amount of work to be done. I believe, are really trying to demonstrate that we respect and don't have the arrogance to believe that we know all the answers, and we know that our sister organization, the Indigenous nurses and the Indigenous physicians and other similar groups, are really the wisdom that we have to tap to understand this better.
Thank you, Chair. My question is on the same line. I just saw this statistic, which is surprising even to me. 28 to 29% of Canada's seniors are immigrants. That means they weren't born in Canada or they did not have Canadian citizenship when they arrived. Most of them live in Toronto and Vancouver. There's another fact that I think plays into this, and you know this. The older you get, the more pain you have, the more likely you are to lose your second language. Language attrition happens with age and with pain and suffering. I wonder if you can comment on the public policy response to the huge representation of immigrant seniors in the Canadian senior demographics, and second, this particular context of language and services in a language, and whether that public policy response is contained in C277, or we can see some response in the bill.
That is a very important question, and I'm not sure I'm fully equipped to give you much information. What my mind goes to as you're speaking is a separate issue that is a confounding factor in this, in your question, which is not only are let's say 30% of Canadians are originally from another country, but that proportion would also translate to the nursing profession. And we do not have perfect systems in place right now for migration of nurses into Canada and to achieve their registered nursing status. There are challenges in that system as well that we continue to work on. And we continue to work on them not only because we want new Canadians to have viable employment and excellent opportunities that they've come to Canada for, but also they're representative of the different languages and cultures who we care for in hospital. So I think there are a number of moving parts here, and I don't want to bring information to the table that's inaccurate or misleading, but I would say it's a very important question that you're asking, and having a nursing workforce or a healthcare workforce overall that is reflective of the Canadian population as it exists is very important.